So we're a bit behind schedule, so want to get going straight away. This session has as its theme transformation of the US healthcare system. And that's a daunting task. It is by far the world's largest healthcare system. 2020, the US healthcare system turned around $4.1 trillion, 19.7% of GDP went to healthcare. It's fair that 2020 was a COVID year, but it's still an awful lot of money that went to other things as well. It's interesting, I think, that the US healthcare system, 50% of the total spend is actually public spend. If you take the federal, the state, and local spend, 50% is public. The CMS Innovation Center, CMMI, received, all in all, over the past 10 years, its first decade, $10 billion to innovate, to drive innovation projects in healthcare. And if anything could be called a moonshot to really invest money behind innovation, I think that's fair to say that that would be the one. Because even the Dutch government and other Singaporean government has put significant investments behind change. But I think it's fair to say that the CMMI investments were probably the largest in order to drive innovation in healthcare systems. The strategy refresh that came less than a year ago from CMMI describes the learnings, and you heard earlier from Dr. Raval some of the learnings that's come out of that. But what we'd like to discuss with this panel is what we have learned during the 10 years. And Liz Fowler, who is the director of CMMI, was supposed to be, and she is with us now. That's fantastic. Welcome, Liz. The panel we have to discuss this topic is, it's a very exciting panel. So Liz Fowler is the director of CMMI, and the most senior official, I would argue, to lead the transformation work that CMMI has been tasked with proposing the direction for. We have David Lansky, who has been the CEO for many years for one of the pioneering healthcare purchasing organizations, PBGH, in the United States. He wrote a very interesting article in Health Affairs recently where he argued that we need a wholesale replacement of our system for measuring healthcare quality in the United States. Of course, a theme that we like at this meeting. And then finally, we have Mira Mani, who works at Town Hall Ventures. Town Hall Ventures is one of the private equity firms that has invested in innovative providers such as Oak Street Health and others who have taken a very radical approach to changing the care delivery. And you heard Dr. Buchanan from Oak Street Health and how he described how they've delivered primary care, something that I would argue is very different from much of what we see elsewhere. Now, Town Hall Ventures has made investments in this space and is one of many private equity firms who have found the Medicare Advantage program that's come out of the past 10 years of CMMI innovations and invested behind innovations. And in some cases led to quite disruptive change. So what we'd like us to discuss, the three of us, or the four of us, is what will it take to drive disruptive change? The Medicare Advantage is a program that many have described as very successful, but others have a very dramatically different view. None less than Don Berwick has argued that this is draining resources, public resources, into the pockets of venture capital. So there's some tense debates, which some of us who are Scandinavian can recognize from our home country as well. But with that, I'd like to hand over first to Liz, and then after that, David and Mira to share a few thoughts. And I'd like for us to keep it at 5 minutes on the topic, transformation of the US healthcare system. Where are we and what are the priorities going forward? Liz, can I hand over to you first?
Sure. Thank you, Dr. Larson, and I apologize that I'm not there in person, but it sounds like you had a great session with Dr. Purva Rawal, who's our Chief Strategy Officer of the Innovation Center, earlier today. I think those of you who are familiar with the Innovation Center know that we were created as part of the Affordable Care Act. Although most people think of the ACA as a bill or a law that was intended to expand coverage to the uninsured in the US, there were a lot of members of Congress, and I was working on Capitol Hill at the time, drafting the legislation. There were just as many people interested in testing new payment and care delivery models that could improve quality or reduce health spending. We have, as Dr. Larson said, $10 billion that renews automatically every 10 years. So we're on our second 10-year journey. And we've tested over 50 models. We've impacted millions of beneficiaries in Medicare and Medicaid and thousands of health providers and plans. I think you've heard probably from Dr. Rawal some of our lessons learned about not enough focus on health disparities or Medicaid. Our models overlapped. We spent a lot of time in our first decade maybe throwing a lot of spaghetti against the wall to see what sticks in terms of transformation and health system change. But some of those models overlapped and they conflicted with each other. Voluntary models have led to risk selection and may have increased spending instead of reduced spending. And a lot of providers have been unable to or reluctant to accept downside risk without an inducement, which then makes it difficult to make our numbers work in terms of defining success. So we've laid out our objectives in the strategy refresh, and I'm confident you might have heard about earlier today the tenets of that strategy, but really we want to drive accountable care. We think that everybody in Medicare and the vast majority of Medicaid beneficiaries should be in a care relationship with a provider that's accountable for their total cost of care and quality. And you were mentioning Medicare Advantage earlier. Medicare Advantage plans are capitated, but sometimes they pay providers based on fee-for-service. And so we want to make sure that Medicare Advantage also is living into this notion of accountable care and also accountable for quality in a way that we'd like to see and helping patients navigate the system. It's been a year since we released the strategy refresh, which also includes elements including health equity, advancing health equity, focusing on out-of-pocket costs, and trying to align with other payers in the system. We're working on a one-year report that recaps our accomplishments and continues to fill out the roadmap where we're going. You know, in terms of how I'd measure success in the next 10 years, it's really, are we making progress towards those accountable care goals? I think one of the, you know, in our pre-session, our prep session for this panel, we talked about what key barriers might be, and I think, you know, we saw during COVID that the providers that were invested in value-based care were more successful and more resilient in managing COVID, and we had hoped, many of us had hoped, that that would be a catalyst for more providers to move into this space. But I think we're still dealing with the COVID aftermath. Particularly, I hear as I go around the country and talk to providers that staffing, workforce challenges, and really are making it more difficult to move into value-based care. And so we see a little bit of a hesitation, which I think is one of the potential barriers for us to be able to demonstrate success over the next 10 years. And, you know, that willingness of finding partners to join our models. Maybe I'll stop there and turn it over to the other panelists. Again, I'm happy to be here and particularly to share a stage with David and Mira from Town Hall Ventures. So I'll look forward to the conversation.
Thank you. Thank you. David?
Thank you, Stefan. So I want to say a word about my journey here because I think it's relevant to answer the question of the panel. I started working on this field of measuring patient outcomes to influence quality of care in about 1986, so it's almost 40 years. And I worked initially with a wonderful heart surgeon who made a personal commitment, this is in the 80s, actually he started in the 60s, to find out what happened to every patient he did surgery on until they died. And out of his own pocket, he tracked every patient annually had big meetings in ballrooms like this of his patients so they could see each other and also talk about their quality of life and quality of experience. He didn't have the benefit of structured measure sets, but he had the spirit of measuring longitudinal outcomes to improve quality as a clinician. I helped him explore the world that was emerging at that time in the 80s of patient-reported measures as a supplement to the clinical measures that were more familiar to him. And we went on a journey through his organization, then eventually the larger Providence Health System, where some of you now work, to figure out a way to measure those kinds of outcomes across the system. I ran into Paul Elwood in the early 90s, who was known at that time as the founder of managed care, because he had worked with President Nixon in the 70s to have federal managed care legislation, the HMO Act. And Paul then worked with then President-elect Clinton in the early 90s to develop what became the managed competition model. So this is an interface, as we talked about all day today, between the private sector and the public sector. And the question of the managed competition model was how do you use government regulatory power to create a competitive environment for healthcare where those who provide higher quality outcomes, not per se higher quality care, but Paul was very focused on accountability for outcomes and transparency on cost. And the belief at the time was the consumer would make choices in a competitive marketplace that would drive improvement, both clinical improvement and efficiency. So I had the opportunity to work with him for a number of years in an unsuccessful effort to influence presidential and legislative policy. And then in the mid-90s, we started a new organization, which is in a sense a predecessor to ICHOM, called FACT, Foundation for Accountability. And that organization produced a number of measure sets, not as many as ICHOM has, but probably 10 or 12. And the intention, again, was to have health systems adopt them to measure patient outcomes and measure clinical outcomes and offer forward to the community those measure sets and their results as reasons to attract patients. I have a better result for knee replacement surgery than my competitor down the street, and that would attract patients and purchasers and health plans. That effort effectively stalled, so we shifted to a consumer-facing strategy in the early 2000s in the belief that giving consumers direct tools with the emerging internet capabilities would let people vote with their feet, and they would demand quality, measure quality themselves through their own self-reported outcomes, and that would drive a competitive marketplace. And that led me to work on the subject of personal health records, starting in 2004, which was an attempt to figure out why can't people get access to their own health information and share it with their providers instantly, efficiently, and transparently as they were beginning to do on the internet. So that's almost 20 years ago. And I think the same challenges, and that ultimately had modest success, but as all of you know, we don't today have a longitudinal personal health record. And though we've been at it for 20 or more years, it's still a significant challenge. And then finally, I made the stop at what is now the Purchaser Business Group on Health, which is a coalition of about 40 large employers and public agencies, like the state of Washington, the state of California, who buy a lot of healthcare for their employees. And my belief was that purchasers could work together to demand improvements in outcomes and quality by the way they contract. So we did centers of excellence based on outcomes. The group is now working on advanced primary care based on outcomes. And that was a method for driving attention to outcomes. So what have I learned from this journey across a number of sectors of trying to influence this? First thing is that it will not happen by itself. And even the best intentioned, earnest providers who do great things with these measures in their organizations will not automatically replicate or scale. The only mechanism, I think, to drive sustained change in the United States is the government, and I mean the federal government. It's worthy to consider state experiments along the way, but the federal government has to drive it. The second major barrier we're going to have to confront is the IT infrastructure, which is still provider-centric. It has to become person-centric. That means inverting the way we think about the IT infrastructure so that it is based on me and my longitudinal comprehensive health information, which I share with and take from the providers that I interact with. And then finally, I think these two things won't happen for a lot of reasons we can talk about unless there is strong advocacy on the public sector to make these changes happen. And that means that people in this room, clinicians, payers, patient advocates, have to get together and form essentially a political movement to demand that these kinds of changes take place. because there are too many institutional barriers in this country to prevent them from happening through natural process.
Very interesting. Let's move over to private equity, and that could seem as a long leap, but not necessarily.
Yeah, not necessarily. Since there's much has been said, including in this conference, on primary care models, I'll focus a little bit more on the rest of the 80% of healthcare, so specialty, higher acuity care. When we, PE and investor back, so Town Hall is both venture as well as growth equity. And so when you think about investor-backed models, right, they've been prevalent in primary care, and frankly, they've been prevalent in specialty care, and I expect it will gain momentum in the coming years. And there's a few things that go into it. I think first, as Liz said, we're sort of done with version 1.0 experimentation on some of these models. What I mean by that is, through the CMMI programs on Medicare, through the Medicaid and all-payer state innovation model programs in states like Ohio, Tennessee, a number of others. These programs were a number of these programs were explicitly focused on improvements outside of primary care. I know as a physician, as a consultant, I worked on some of these programs. So these are focused on procedures, think hip and knee replacements. They're focused on endoscopy, colonoscopy. They're focused on perinatal care. They're focused on ADHD and oppositional defiant disorder. So specialty care. And some episodes were a whopping success, others not so much, but there were a number of lessons learned, right, by all stakeholders, including some of the investor-backed companies in the space. I'd say the second thing is the market's asking us to go there. Primary care accounts for 20–30% of the $4 trillion plus in expenditure, so we're going to need to go somewhere else if we have to bend the cost curve. We know healthcare expenditures are on track to outpace GDP growth by 200–300 basis points over the next 5 years if we're lucky, and that's if we're lucky. And I think there's a continued recognition that a fee-for-service system generates wasteful, even predatory practices that don't serve members well. So maternal health, if we had better incentives on better prenatal care, there's less incentive to, do avoidable C-sections or end up with very scary and expensive NICU stays just so you can fill heads in beds. There are, say, a revolving door of preventable relapses for those with substance use disorder who are treated in shoddy, suboptimal, if not outright fraudulent facilities. And there's a lot more we can do in an area like kidney care, right, to delay progression to dialysis than we're currently doing. So those are just 3 specialty examples of innovation. Town Hall has companies in these spaces, and we continue to lean into innovation like this because we believe it's necessary to extend well beyond primary care. The last thing I'll say about scaling this type of innovation is nobody does it alone. I think what investor-backed companies bring is a pretty exciting combination of talent, of agility because we're small, and I would say relatively patient capital. Many of the investment horizons can be 10+ years, and a willingness to take a bet on something that's early stage, speculative, and has a high probability of not working so well. But you do it in partnership with a strategic, right? Large strategics bring scale, bring experience. So there's a lot to like about that pairing, and in my opinion, the investors and the investor-backed companies that will prevail in making a difference in healthcare will be the ones that really lean into this form of partnership.
Very exciting. So I want to do a couple of questions from my side and then open up to the audience. I think one of the areas that I've looked at I found most interesting is the Medicare Advantage, the capitation model. And the Oak Streets and others have come on the back of that model and been able to fundamentally deliver primary care in a very different way. Now, it has been criticized. Medicare Advantage is now 50% of all Medicare eligible, so it's a big program, and it has grown quite fast. Several who publish on this have said it's a great success. Not that it saved so much money, but patients have gotten a lot extra that they didn't have. They get dental care for free as a top-up with the same cost. So savings haven't necessarily been big. The patients get a lot more health out of the programs. But others, and Don Berwick and Richard Gilfillian have written a couple of papers saying that this is shifting money from the public sector to private equity, et cetera. And I'd like to, and there's in fact been another line of criticism, a line of articles recently in the New York Times that argue that the risk adjustment, the reporting of comorbidities, et cetera, has been outright fraudulent, and there's actually court cases taking this to be scrutinized properly. Now, I'd like to maybe ask you, Liz, first. I would argue it's not surprising that when something is transformative, there will be a lot of resistance and there will be a lot of challenge. How do you see the criticism from the likes of Don Berwick and Richard, as well as the accusations of fraudulence? Is this something that surprises you? Is it something that concerns the fundamentals of CMMI's initiative and CMS initiative when it comes to Medicare Advantage?
Well, maybe let me start first by addressing the article by Don Berwick and Rick Gilfillan had two parts, and the second part was aimed at one of our models, specifically the global and professional direct contracting model. So the first article was squarely a criticism of Medicare Advantage, as you explained, and the second was a criticism of the GPDC program. And I wanted just to be clear that there's a difference between those programs, and their criticism of the GPDC program or the model was that it ran the risk of becoming a feeder into Medicare Advantage. And we have addressed those criticisms directly. We have shifted the program to be more focused on provider-led organizations. We have beefed up screening and compliance. For the second round of applications, we accepted less than 50% of the applicants based on the screening criteria we applied. And we included a number of equity elements. We are adjusting payments, the benchmark payments, based on providers that care for a higher proportion of underserved populations will receive a higher payment. We require health equity plans. We are requiring collection of data. So I think, so I just want to point out that the criticism has been leveled at our model, we believe has been addressed. Turning to Medicare Advantage, and when it comes to Medicare Advantage, CMS is committed to putting patients at the center of their care and people at the center of their care, and really driving to a future where people with Medicare receive more equitable, high quality, and whole person care that's affordable and sustainable. And as we drive towards this vision in Medicare, Medicare Advantage represents a piece and a part of achieving those goals, especially as enrollment has reached, as you said, half of all enrollment in Medicare. We see an opportunity for partnership with Medicare Advantage plans and other MA stakeholders to better understand how care innovations are changing outcomes and costs, how to ensure that MA is working for enrollees, and drive further value of the Medicare dollar and health of beneficiaries. At the same time, we're committed to making sure that Medicare dollars are used efficiently and effectively in Medicare Advantage. And earlier this fall, you might have seen that CMS issued a request for information asking for input on key questions that will be used to inform future policy. And I think it's too soon to say how that future policy will evolve based on that input and feedback, but you can bet that we're looking closely at input we've received from all sides of this debate.
So I think it's clear to anyone who's looked at, and you heard Oak Street talk today. I mean, it's been a tremendous set of innovations they've done. They bring a completely set of offerings to patients in groups of the population that are very much underserved. So the level of innovation, I think, is undisputable. So I think I'd like to turn the question around and say, could we, in a similar model, use the principles of Medicare Advantage to have the same level of innovation for other parts of our healthcare system? And I think you described that. You're actually investing in not only Medicare Advantage or general practice, but in other parts of the healthcare system where there's ideas of driving fundamental innovation as well. And I think it's a question to all three of you, in fact. Yeah. Do you see that the level of innovation that we've seen as a result of Medicare Advantage could be replicated to other parts, and what would that require for that to happen?
I'd say that the interest in that innovation has expanded and not by any means not receded. Why? Because from the investor community's perspective, there are proof points, right? Both the public markets as well as the private markets have said that they value innovation in healthcare just the way they value innovation in technology, which has resulted in the emergence of healthcare unicorns, so companies valued at $1 billion or higher, or even decacorns, companies valued at 10 billion and higher. And before that, just used to be tech companies that did that, right? Startup was a tech thing. So as a result, right, of this, and some of it admittedly is just the market conditions, it's going to be different this decade for sure. But still, as a result, there is now available capital, dry powder, of north of $100 billion, 150, that investors are willing to deploy against companies that will align to the quadruple aim and will deliver, but while delivering robust returns, right? That being said, I think the only way to do that and to build these durable companies is by aligning it with value and doing it in a responsible way, period. A lack of trust in the court of public opinion is not going to help any stakeholder, especially the investor community. It's just bad for business, right? And it's the right thing to do foremost, but it's bad for business, right? So the incentives are aligned. I think then it's just do the hard work, embrace the criticism and the critique, right? Respond to it, as Liz mentioned, and take good care of people, and yes, be financially astute about it, right? I'll say, the final thing I'll say just on is around guardrails. I think the systematic overuse of risk adjustment, which has been a significant portion of the critique of the Medicare program, is not a purview, it's been across the board. So if you look at the listed entities, and I won't name the entities, in the report, it is a nonprofit, it is for-profit entities, it is investor-backed companies, right? So it's not, I think greed is universal, if you want to call it driven by greed. And so, you know, let's, yes, we all need to do better, and we would all benefit from, you know, better guardrails, right? Whether it's a commitment to evolution.
David?
I won't claim any expertise on Medicare Advantage. I think the chassis is relevant to the discussions we are having here, and it could be built upon. But I think there's not enough on that chassis to get us to real value. And I don't think there's, I mean, obviously for those of us at an ICHOM meeting, you would immediately ask the question, can Medicare Advantage plans show better outcomes of the kind that we work on, measure, and the measure sets, you know, how many ICHOM measure sets have been adopted by MA plans? And do they have the capability to even measure those things? And that, to me, points to the kind of Achilles heel of those plans so far, which is they don't have a mechanism for clinical coordination. And they are essentially financial engineering platforms. And until they build the capability of managing care for a population, coordinating the care for a population, measuring and reporting on outcomes, competing on those outcomes, then I don't think they're getting to where they need to go. So I wouldn't rule them out as an important tool in our arsenal, but I would dramatically strengthen the platform if I were going to bank the Medicare program on it.
Right. One of the things I found really interesting when I discussed with Oak Street was that the HEDIS measures, which is what they report, in fact are process metrics. But what Oak Street has done, they've put together a large number of true outcome measures, and that's what they measure themselves against. We actually spoke to Mike Peacock, the CEO, and asked him to review the ICHOM standard set for multimorbid elderly. And it turns out they have themselves started measuring 24 of the 28 metrics and hadn't even looked at the ICHOM sets. So they drive themselves by looking at outcomes, although they're not reporting it. So maybe, Liz, back to you. And we had Dana Safran on stage earlier today together with your colleague. And of course, Dana's been given the mandate now to start defining true outcome measures that could be used once validated in the CMS system. Do you see that the HEDIS or other quality reporting scales in the future would, as David alluded to, you know, demand true outcome measures? And if so, do you think that will fundamentally change the likelihood of, you know, fudging the numbers, et cetera, or drive change of the kind we're all talking about here? How far away do you think that is for CMS to change the 90% process metrics to 90% outcome metrics?
Well, first let me say that I'm a huge fan of Dana and the the role that she's playing and the job that she's doing at NQF, the National Quality Forum. We're also very supportive of her efforts to work with private payers to align on some of those outcome measures and identify gaps and fill those gaps. And I believe they're looking down the road of potential work with ICHOM as well. I think it could make a difference, and certainly we at the Innovation Center want to evolve to a place where we're really focused on fewer metrics and metrics that matter. So the notion of moving towards outcome metrics is, instead of these process measures, are very important to us. And we've also committed to including patient-reported outcome measures in our models as an effort to capture the patient perspective in what we're doing. You know, you mentioned that there's so many process measures that are used, and part of that's in the law, the macro law, the law that changed the Medicare payment fee-for-service payment system for physicians continues. A majority of those measures are process measures, and I think as we look down to what we are able to change, of course we need to be moving in this direction, but we may need to also consider you know, new legislation that moves us away from where we are today to where we want to go.
Great, thank you. So I'd like to open up for questions from the audience. Here is a couple of hands down here. Microphone, please. Yep.
Thank you all for your comments, and especially Dr. Lansky, about your comments about some of the limitations of Medicare Advantage. One of the things that has concerned me, I love some elements of the Affordable Care Act, but I think one of the unintended consequences of putting in the STARS bonus for Medicare Advantage plans has had a horrific unintended consequence. It has made quality measurements of process, most of them are process measures, almost nearly a financial exercise, and very little in the way of learning and improvement. And my question is there any way we can back out of that and get to the point where even if we start measuring outcomes that matter, that they're designed to improve and not to rank and reward, because there must be multi-tens of billions of dollars at risk if you go from at least a 4-star down to a 3.5-star.
Any thoughts?
Well, I'd say that's something the agency is looking at really closely, and how much flexibility and how much ability do we have to maneuver in that area. So like I said, we issued a request for information, asked a lot of questions, including about quality metrics, and expect that we'll have more to say about that as the time nears.
Maybe one thought on that is, we heard in one of the previous discussions that payers may pay for you to gather the data and report it, but not going to pay you for the performance as such. So fudging the numbers is not going to give you any more money. We want you to report. And cooking the books, if we describe the reporting of outcomes as important as any financial reporting, cooking the books, you go to jail. So you need to report it, and payers are willing to pay for it, and reporting it, misreporting it, is you know, a really bad thing to do.
There are two other angles to that, building on your comments, Stefan. We had something called a measure cascade, and the idea was to have a staged process over, say, 3 years or 4 years, where year 1 was measure to demonstrate you can measure. Year 2 is to demonstrate that you can measure a change over time for a patient, a pre-post of some kind. And the 3rd year was to measure for reward. And the 3rd year strategy could either be done on relative improvement or absolute attainment to a benchmark. So I think there are ways in the mechanism of implementation to try to address that.
Yeah. The only thing I'd add is, you know, while imperfect, having a rubric is better than having no rubric. We know that the rubric is driving behavior change, and we know that you know, whether it's the changes in cut points or double weighting of caps, starts getting people's attention on the kinds of issues you want to get them attention on. And, you know, there's a signaling effect, right? Because what follows from that is what follows from Medicare is private insurers actually following, because the alternative is everybody makes up their own, and that's severely problematic, especially for the people at the front lines delivering the care.
Questions down there? Yep.
Good afternoon. Before my question, I just want to respond to the last speaker or the questioner's comment. I led the quality operations at one of the largest U.S. healthcare companies when the Medicare Advantage Stars program started to pay money, and I can tell you that my budget went from very small to very giant in terms of being able to drive health improvement activities. So I think that I'm an advocate of teaching to the test as long as you have a good test, and I'm a big advocate of the STARS program and its payment methodology. So I think it's fabulous. The money that the plans get, they have to put back into benefits for the beneficiaries. It's not like they can put that money into their pocket. So, you know, Liz, I don't know if, I know you weren't at CMS yet when that got put together, but I think whoever put that program together was brilliant, and I'm a big advocate. Yes, we should be moving to outcome measures. Now my question. So we have a lot of kind of fragmented measurement systems in the U.S., including Hospital Compare, the Medicare Advantage Stars program. We have, you know, through CMS. We additionally have external quality assessors, entities like U.S. News and World Report, Health Grades, et cetera. And I think we would all be better off if we could get to a common measurement system. And even if you look at kind of some of the hospitals that are in Medicare Advantage, for example, you know, Kaiser, you know, which has very, you know, 5-star health plan, we don't really see them so much in Hospital Compare because their Hospital Compare is based on fee-for-service Medicare data rather than Medicare Advantage data. I'd like to know, you know, how we can get to a common measurement system. My dream would be to see a measurement system where we're even reporting out commercial claims, and maybe, you know, David can comment on that. But if we can have a single kind of common set of metrics, including patient-reported outcomes and important process measures, I think we don't want to throw the baby out with the bathwater. There are very important process measures. You know, how can we get to that place where we have a common set of measures and measurement across all insurance companies and all providers?
Well, I'll say that it goes back to, I think for me, the person-centered way of thinking about the problem, rather than the payment model or institutional way of thinking about it. If we do the latter, which is what we've been doing, you inevitably have fragmentation because it's in the self-interest of each entity to both protect its data, to hide it, sometimes to fraudulently game it, and there's not a willingness to come together to a common measurement platform. I've been to many, many meetings where we invited people to agree on common measures, and it invariably blows up. It's just not an intrinsic reason to do it. So I think other than having it be imposed by CMS, there's more of a sort of a person-centric strategy. I'll give you one slightly off example, but to illustrate your point. When the purchasing group I was with wanted to do centers of excellence for orthopedics, we had an RFP, an RFI, went around the country, interviewed all the prominent orthopedic hospitals and health systems on a standard set of metrics. And we did require that they be doing what's now the who's coos. They had to be doing standardized orthopedic outcome measures, and for knee and joint, for knee and hip. And so all the ones we talked to were actually already quietly collecting that data, but not publishing it or sharing it. When the purchasers came in and said, we will only contract with you if you produce this data in this format, surprisingly, one of the Kaiser hospitals, even more surprisingly, in Irvine, California, was one of the nation's best outcomes in orthopedic surgery. Now, we would not have known that from any other data platform if we hadn't purposefully gone in and required that kind of reporting. So I think you can sort of level the playing field if you have a powerful purchaser insist on a set of standards.
I think the only add to that is, it's, the federal level through purchasers and through states, right? So state, all payer, so commercial, so no opt-outs. You have to agree on a set of measures. It's not for every clinical condition, but you have to agree on the measures. Private sector can decide how you want to pay for it or not, but the measures are the measures, right? Got to come together. And so I think it requires that level of, some level of mandating. Yep.
No, I think, and we need to wrap again. I have a big red zero in front of us here. But I think Galileo Galilei wasn't, a genius. He had better binoculars than anybody else. And that's what allowed him to understand that, the planet Earth was not at the center of the universe. And I think that if we can create the binoculars for healthcare, that we measure the same thing, we will see things that we have never seen before. Irvine is better than somebody else. And so I do think the standardized measurement is absolutely key. And unless we do that, we're going to keep doing the wrong things over and over again, and it's going to be more and more expensive. So I do think it is the lever, as I said earlier today. This is the lever to change. I want to thank the panel, Liz from a distance, and for David and Mira for participating, for good discussion, and thanks to you for good questions. I expect that we have another break now. Nobody tells me else. So have a nice break. Thank you.
Thank you.